Audio some problem.
Yeah, it is breaking, freezing in between. Audio is not coming. Audio is not coming and video is.
Yeah, I'll check it once again. Yeah, I'll stop sharing and then I'll check it once again. Welcome to SENADHIPAN Education Foundation. Never stop learning because life never stops teaching. Actually, we started this knowledge exchange platform in 2012 by releasing a set of educational DVDs. It was released by none other than Dr. Sion Han Kim in Jan 2012 at Trivandrum. And he visited our place in 2012, and we were having contact classes and educational programs till July 2020. Because of the COVID, we changed to online platform, and our logo was released by none other than the king of laparoscopic surgery. We are blessed to have him here also in this platform.
Thank you, sir. Now I welcome Professor Para-Aortic sir, Chairman, GEM Group of Hospitals and Research Center, and the Founder President, AMASI, for releasing the logo of SENADHIPAN Education Foundation and for the inaugural address. Over to you, sir.
Yeah. Thank you, Nisha, and thank you, Baiju, for inviting me to be today's more remarkable event, part of this. And was a good friend of mine, and since he started laparoscopy, very happy about it. Dear friends, Parvinder Lal, Professor Parvinder Lal, Vice President of National Board Examination, and John Abraham, ASI, ex-past President, and friend Raman Koil, President of IAGS, and Baiju. I think great happiness to be here to launch the logo of SENADHIPAN.
Thank you, sir, for joining us today. After that, we started having online live surgeries, live lectures with eminent faculties across the globe, and started having certificate courses for online courses. And we have 3 WhatsApp group of 256 each, and we have got a SENADHIPAN Education Foundation Facebook group. Last week, it was Subhash Gupta who gave the talk on my journey through 3,000 living donor liver transplant. Actually, it was participated by almost 1,000 surgeons across the globe from 56 countries. And that is available in our YouTube channel for free. And you can subscribe that YouTube channel, SENADHIPAN Education Foundation. Today, we have 2 brilliant oncosurgeons in our platform to talk about laparoscopic para-aortic lymphadenectomy. Dr. Subramanyeshwar Rao, everybody knows, I don't have to tell. you about Dr. Subramanyeshwar Rao and also Dr. Somasekhar, who are my friends for long, and Dr. Chandramohan from RCC will be introducing them. Chandramohan is a senior oncosurgeon from RCC Trivandrum. He is the academic face of RCC, spokesperson of RCC, and he is a senior oncosurgeon doing a lot of laparoscopy work. Before starting this program, some instructions to the participants. All participants are requested to mute their mic on entry. If possible, kindly acknowledge your name by renaming your device. Participants logging from outside India are requested to reveal their identity in the chat box. Raise your hand if you want to intervene. Everybody will be given permission to unmute their mic and speak to the speaker. If you are on a portable device, please mute your audio and hide your video. And you are requested to hide your video while presentation, because the clarity of presentation will be better if you are hiding your video while Dr. Subramanyeshwar Rao is presenting. And you can contact us and SENADHIPAN at gmail.com for any queries. I hand over the mic to Dr. Chandramohan for introducing the speaker and the moderator.
Thank you, Dr. Baiju SENADHIPAN. Can you unshare your slides so that I can share it?
Yeah, I unshare.
Can you see my slides?
Yeah.
So, thank you, Dr. Baiju, again for this fabulous opportunity for me. I think the COVID has created a lot of hurdles for the humanity. But one thing which good happened after COVID is the lot of academic programs like this weekly online meetings Baiju has started has become a reality. And can't you imagine nearly thousands of people are attending from various continents, and I'm really happy because Baiju is a close friend of me, and he's a good academician, and we all started doing laparoscopy, looking at him, taking him as a role model and advisor. And I'm also happy that this Trivandrum has become the hub of academic activity where the entire world is listening to us. And today I am extremely happy because of this reason. Faculty I am going to introduce and going to capture the audience today are in fact my pioneer, my leaders, and my friends. And in fact, this photo which you are seeing now is clicked by me only. And I introduce Somasekhar ST first. Professor Dr. Somasekhar ST. He is MBBS, MS, MCH, Surgical Oncology. Also, he is an FRCS in Edinburgh. And he's the chairman and HOD of the Surgical Oncology of Manipal Health Enterprises Private Limited. And he's a consultant surgical robotic surgeon. And one thing he's the world leader is HIPEC, and the second thing is robotic surgery. And you won't be surprised, he is a highly accomplished faculty for various foreign universities, and you see him presenting in meetings such as ASCO and other important international forums where he goes as invited faculty, which is something which is heartening for us, and that is why I think he's a role model for surgical oncologists of India. And coming to if I started reading his biodata, I think the allotted time for the CM is not sufficient. Empty number of awards, and whatever research he is doing in the first quality research, not only in HIPEC and robotic surgery, but also the translation cancer research and various aspects. I'm pretty sure that his hospital as well as his lab is going to have some breakthrough discoveries in translational cancer in near future. And his international and national accolades are many. He's really the pride of surgical oncology fraternity of India. And he has the real pillars of his success is his wife, Dr. Manjari, and his daughter, Aditi and Neha. Of course, he'll be showing the daughter's slides everywhere. And I'm also extremely proud that we studied the same college for MCH. And these are our friends, and actually we are all very happy and very proud of Somasekhar leading us. And we also have a connection with Trivandrum because he's a constant faculty for our gynec as well as GA meetings. And not only that, he is the main supporter of most meetings. I think NATCON ISO 2018 was I could do it only because the support he gave in terms of sponsorships and etc. And he is with the royal family of Travancore when he visited us in 2018. So I think he belongs to Trivandrum. Not only that, any day, if we are needing help in the field of robotic surgery or high-tech, I think he will be ready to fly in and help us. And I have experienced that readiness many times, and I think all of us will be released same way with his help. And this is Dr. Somasekhar. And coming to Subramanyeshwar Rao, this is again a picture clicked by me in Russia, where we visited a meeting. And he's the director and chief of surgical oncology, Indo-American Cancer Hospital, Hyderabad. And he was formerly a professor of surgical oncology of Osmania Medical College, Hyderabad. And thinking about T.S. Rao and speaking about him, he's an accomplished leader of surgical oncology. He has, in fact, developed the laparoscopy in surgical oncology in a significant way. And umpteen number of publications and the reviewer of good journals, and he was a past secretary of Indian Association of Surgical Oncology, and he's holding so many posts in ASI as well as Indian Medical Association. And all these photos are clicked in Trivandrum when we came for all our major endeavors. He came to support us when we inaugurated the meeting. The Association of Surgical Oncology came in, and somebody we rely heavily. And of course, there's a Kerala connection which I like to enlighten here. And his wife, Sikala ma'am, is from Kozhikode, and she has two smart young daughters, Jojo, younger one, and Aishwarya, older one. I think they are actually pillars of his support, and I'm happy that his family is controlled by a Malayali. And of course, he's a fit person. You can see him. The success of him is regular physical fitness. I think he in a meeting yesterday, which happened in online, he came in, and this was the director of sports of national, the Ministry of National Ministry, and we were in a meeting, and Subramanyeshwar Rao sir was the main faculty here, and he was talking about the exercise and breast cancer prevention, and this happened yesterday. I think these few words I'm stopping, but if I keep on describing about these two fantastic people, I think I need a lot of time. Thank you, Dr. Baiju, for this kind of opportunity.
Thank you, Dr.
for your all in the West.
Thank you, Dr. Chandrabevan, for the nice words about the speaker, moderator, and about me also. I have a lot of things to tell about Dr. Subramanyeshwar Rao, especially because when now I land up in trouble or dilemma regarding some logistical issues or something, I always consult him in WhatsApp group. We respect each other, and he gives me good advice when it is required. I request Dr. Somasekhar to introduce the topic, and you can hand over the mic to Dr. Subramanyeshwar Rao, please.
Thank you very much. It's what a great moment it is. We always have very world-renowned orations like the SENADHIPAN Foundation. Most of the time, the award actually crowns the speaker. Rarely in our life we come across a opportunity where the orator actually enhances the foundation and the topic. And everybody in India, on behalf of IASO, all the oncology community, gynae onco community, minimal access academia would unanimously agree with me. Today we have a orator par excellence who actually accentuates the name of the foundation and the oration for which he has been invited. One thing about Subbu is everybody knows him as a technical skill, very good surgeon, but he's an excellent human being, selfless person who sacrifices himself for the betterment of the team. If anybody want to learn what is a team building, an youngster, a senior guy, you need to learn from him. Always the leader is the one who sacrifices all his interest and builds up the team for the benefit of a team. And he is somebody who is a mentor of mentor, teacher of teacher, inspiration for all the people who are senior surgical oncologists and all the budding people. If somebody is not clear now what they should take, all you need to do is make him arrange a visit to his institution or make him listen to his inspirational talk. And next day they understand that this is the person we have to follow and have to be there. He's an excellent human being. It's like, I have learned a lot from him. And whenever he is speaking, there is always things to pick up, not just in the subject, but also in life. And a topic which is so dear to him, me and most of us. Because, in the field of gynecological oncology, it is not what you do in the pelvis. Everybody will do, every Tom, Dick and Harry will do a good job in pelvis, even in minimal access. But what you do in the upper abdomen in para-aortic area, this was sort of a holy grail, unexplored Pandora box, didn't bless many of the top minimal access gyneco people, but it was mastered fantastically by Subramanyeshwar Rao. It is easy to do these things in robot, very difficult to master in minimal access with the given infrastructure. And this is something I saw him over last 7-10 years, starting this Mount Everest journey, and I could quickly see him, he conquered the summit in this. And now gone are the days people would go to Mayo Clinic to learn laparoscopic para-aortic. There is a reverse migration. People would come to learn from Subramanyeshwar Rao. And this is a topic which is very tough to master. He has done it with chisel, hammer, every part of the stone he has chiseled to carve a painting. And it is not about the end result of his video, but the journey he took it and the message. And it's like my honor, and I'm humbled. And I thank SENADHIPAN Foundation and also you, Baiju, SENADHIPAN personally, and Subbu to allow me, it is like a student who is actually presiding over the mentor of mentor, who is going to speak about something which he mastered, which is the toughest thing. Over to Subbu sir, and we welcome you, a warm welcome on behalf of everybody, looking forward for your journey, and we pick up the right thing, and probably we will try to be as good as you in coming years. Thank you.
Sure. Yeah.
What an audience. You have 390 people watching. That means all over the world, almost 1,000 surgeons are watching you. Dr. Subramanyeshwar Rao, we can start, please.
1 second. Is this all right, Baiju? You're able to see the full screen?
Sir, we can see your screen. Make it full screen, sir.
Screen. 1 second. Why is it coming like that? 1 second. Okay. Is that all right now?
Perfect, sir. Now perfect.
In color. Okay. Good evening, good morning, good afternoon, depending on where you all are. I'm truly overwhelmed by the fact that I've been selected to do this talk this evening. And I'm actually choking when Baiju, Chandramohan and Somasekhar spoke so much about me. I really hope this would not deter me from delivering the lecture as I would want to deliver this. There's no financial conflict of interest. This is purely a technique talk. We are not going to discuss where it should be done, why it should be done. We would only be discussing how it should be done. few of the video clips would be in high speed for the sake of saving time. I bow to the pioneers. Many of them have actually logged in. We developed minimal access at a time when specialties were divided. The whole ecosystem was fissured. Minimal access surgery brought all of us together. If I had to look for inspiration and learning, Professor Palani and Dr. Ramesh Ardhanari were very important. I used to travel to listen to them, see them operate, among a few others. In thoracic surgery, I would remember the name of Arvind Kumar, dear friend, who actually showed initially great grit to develop these specialties. And as I started learning things, the oncology community, unfortunately, did not catch this up early. We were discussing about the safety of the procedure, the presence and absence of evidence, while the surgical GI colleagues and the general surgeons surged forward. I was much more open, and I mixed and merged with these wonderful human beings, and they were more than willing to share everything that they knew. And that's how I actually developed much more interest. Baiju is somebody I met in course of my travel throughout the country in the early 2000s, and understood that this gentleman would definitely go places. The way he was presenting the techniques that he was actually innovating, I really understood. I really listened about him a lot, and I've not been disappointed at all. And then we needed to develop, once there was evidence that in oncology, therapeutic oncology, minimal access was safe. Somasekhar, Chandramohan, Ayyappan, and others, all of us have joined hands together, and we feel proud that we have led the way for development of minimal access in oncology, and that made our patients, and that would make the future patients safer. I bow to all these pioneers, because any pioneering work requires lots of grit, lots of gumption, lots of endurance, lots of patience. I can also see lots of my teachers in the logins, teachers who have taught me open surgery. I bow to them too, because of the simple reason that I always believed that open surgery teaching of mine became a platform for this minimal access training. The outline of the talk would be the indications, the concepts, the initial struggle, the evolution, the present day approach, and the troubleshooting when there are problems. The ideal patients for MIS will be high risk early endometrial cancers. That is the most common indication as a staging procedure in ovarian cancer. And the advantage of natural orifice specimen retrieval in these patients stands out when compared to most other oncological procedures. The other indications are germ cell tumors post-chemotherapy with non-bulky residual masses, completion staging for carcinoma ovary when a cystectomy or an adnexectomy has been done elsewhere, and there is documented proof that there is no obvious macroscopic spread. Rarely, it's also used in some centers for carcinoma cervix, wherein you do a para-aortic lymphadenectomy so that the extended field radiation can be avoided. The institute's journey, we started slow and small as the technology and the technique evolved. And as we started out problems in between, in 2015-16, we had run into a bit of a rough weather, and reasonably so, we actually paused for a while, being responsible for the patients, and then sorted things out, and then it climbed up. And we hope to do many more if it's going to be useful to the patient. The probable reason for growing numbers is because it is a tertiary cancer institute of great reputation, and then the type 2 histology seems to be more these days. The radiation oncologists are generally not comfortable with the para-aortic, especially because these patients are very obese. And then the immunohistochemistry utilization seems to be diagnosing many more type 2 histologies, and the need for para-aortic lymphadenectomy comes in with the type 2 histology. What is extremely important is I feel very comfortable and proud that I was trained basically as a general surgeon, because these techniques are extrapolations of a pyramidal training, that the platform being general surgery, which extends into gynae, thoracic, and other areas, vascular surgery. So extrapolation of all this is retroperitoneal lymphadenectomy or the para-aortic lymphadenectomy. The retroperitoneal space is the anatomical potential space behind the peritoneum. The concepts are creating the space. What is much more important is maintaining it and manipulating it so that you resect what is necessary without injuring what has to be preserved. The essential steps are creating the space by mesenteric and mesocolonic flaps, ureter to ureter dissection, and then iliacs to the renals. Maintaining the space by what is called the tent technique. I will elaborate on that later on. And then the appropriate assistant surgeon's utilization. Manipulating the space by riding along the gonadals, IMA and the para-aortic basin. The lymphatics have to be handled carefully. And then I would stress the fact that retroperitoneum is a difficult place for variant anatomy. Added to all this agony is the fact that most of our patients are extremely obese, because the commonest indication is endometrial cancer, and endometrial cancer rarely occurs in thin patients. We cannot be complaining or asking these patients to lose weight. We need to be operating when they are diagnosed, because endometrial cancer is a disease that is diagnosed, staged, and treated surgically. So we'll have to do it as a semi-emergency, so you would need to handle such patients. This becomes easy in open surgery because the entire small bowel can be actually brought out. Exteriorization of the small bowel into a mop or a towel, and then once you exteriorize this, the rest of the procedure becomes much easier. It's harsh on the patient, but it's very, very mild on the surgeon. And once you have two good, robust assistants to retract, these peritoneal cuts are so much simpler. It's in one drive, you complete everything, and everything is in control. There are 6 hands that are operating and retracting. So it makes things much easier for the patient, and much more difficult for the surgeon, and much more difficult for the patient later on. So the creation of the space is essentially exclusion of the small bowel by lateralization of the small bowel, and reaching this space so that you clear from ureter to ureter, iliacs to the renal. Maintaining the space is done by various measures. The time-tested traditional multiple instruments and ports that go in is something that continues to stand the test of time. The other measures are by suturing parts of the bowel, using the appendices. You can use a T-lift. You can use a endoloop retractor and many other things. You cannot have more than 5-6 ports, because you will have sword fighting inside. The left and right hand of the surgeon should move comfortably if you have to achieve. So all these measures would be necessary depending on the anatomy of the patient. 2 ways to go about it. There are surgeons even now who do everything from the right side. We are not discussing the extraperitoneal approach in the prone position or the semi-lateral position, but the transperitoneal approach is done from the surgeon on the right side by some surgeons. We find that alone difficult to complete the procedure, and there are surgeons who do it between the legs. This makes it's difficult to do the lower part of the dissection. So what is important here is to understand the anatomy from the right side, and then change between the legs, the French position, and re-understand, reorient to the anatomy, and complete this procedure. Initial struggle was because staging was considered to be not an absolute requirement. There were enough people who talk about para-aortic lymphadenectomy as not a procedure that is required. and then the mid-abdomen ports were unclear. All the ports that were there were for the pelvis, because the hysterectomy and the pelvic lymphadenectomy were considered much more important. So the anxiety was to do a good job in the pelvis, and how do we use these ports to the mid and upper abdomen was something that was not clear. And the right-sided traditional ergonomics using the tilt and the extreme camera angles were also a cause for the initial struggle. And for these reasons, we would do a central dissection predominantly, which would be an extended staging procedure, and not probably a completely therapeutic procedure. Showing a few videos of the three chip cameras then in 2011. You can actually see that most of the dissection is blunt dissection because we were tentative about the anatomy. First few procedures, we had experience in open RPLNDs, especially for testicular tumors. Most of the dissection in the first video on the left one is the lower abdomen, below the IMA, the lower para-aortic only. We were doing some staging and convincing ourselves that we have done a good para-aortic lymphadenectomy. Right-sided dissections, the limiting factor is that the upper abdomen is difficult to access. If you want to really go to the renal vein in an obese patient, it's something that is not easy at all. And then the next step was to get between the legs. We extrapolated this from surgical skills that were developing in those years, and we could easily achieve up to the renal vein. But what you can see here in this video is that we did not even remove the gonadals. What we were doing is a pre-aortic and a partial para-aortic and paracaval dissection. You can see the small bowel coming in and disturbing at that point in time, wherein we were using 3 graspers to pull and push and struggle. So half the time we were struggling to push the small bowel away. Evolution 1 was when we understood the role of a hypogastric camera. The previous video that I've shown, the visualization was done from the right iliac fossa camera, which did not give a good ergonomics, and we had to do from the left side as far as the dissection was concerned. So the hypogastric camera, the 6th port that we added while we went between the legs of the patients on the Allen stirrups, produced the first solution for these problems. And then the other important problem was the IMA, whether it should be dissected bare so that the para-aortic dissection can be done easily. And then the much more important one is holding the bowel, pushing the bowel, and with graspers and gauze pieces. This had to be sorted out. As we acquired these stirrups, the yellow fins, the Allen stirrups, things became easy. Because in a true lithotomy position, I think it's much more difficult to operate between the legs because the elbows keep hitting the patient's knees or the thighs, and you are cramped for space. Your limit as far as your movement of your hands is the patient's body, which becomes difficult to complete these procedures. And it would have been always important to have at least 2 monitors, a surgeon screen and a slave screen, which shift according to the position of the surgeon. Those are the ports, and these are the T-lips that I was talking about. The camera port, the right hand and left hand working ports of the surgeon. The assistant trocars, this was a 5 mm for a long time, but when we had a problem, we changed this to 10 mm up front so that a gauze piece can go in and various other clips and things can go in. And then the hypogastric camera, we used to use a plastic cannula here, but we changed over to a Hassan's trocar because the visuals are much better in a Hassan's trocar because the wall, when it hits the telescope, it spoils the visuals, and you would need high resolution visuals to complete these procedures. Surgeon and assistant positioning between the legs of the patient, and the camera surgeon should be sitting here on the left side because it's a long procedure, and And because the hypogastric trocar is at a lower level than the right and left hand working ports, the camera surgeon is much more comfortable sitting, both for himself and the operating surgeon. Despite all this, it is still a struggle. You keep pushing small bowel like this to achieve it. And then there are frequent interruptions. While you open like this, suddenly there is a loss of pneumoperitoneum. The entire small bowel caves into the operating area, and then you tend to lose all the instruments submerged within the bowel loops. They have to be brought out carefully, and then you need to go back in one instrument after another. This is something that can really test the endurance of the surgeon. And then the room for instrumentation in a morbidly obese patient with the small bowel coming in, if you push into the space hard, what happens is the small bowel overflows because there is limited space outside the tent also. So if there is a problem here, it's much more difficult. There was a bleed here, and you can see that because the suction was taken inside, suddenly the bowels come in and produce problems for the surgeon who is already anxious. And then the counterintuition that happens with these ports. On the right side, we were using the hypogastric trocar to do the retraction of the peritoneal flaps. On the left side, it is the upper abdomen, wherein you can see that from the supraumbilical trocar, even for an experienced surgeon, it is so difficult to actually hold on to this and then retract. Hypogastric trocar that is coming in here, the movement of the instruments here are so rusty and so much of inertia because the camera is in the umbilicus and the port is coming in perpendicularly opposite. Counterintuition in minimal access comes into play only when you are actually looking to the instrument is looking at the camera head, and that comes into play in this procedure at some point of time or the other. So if you want to keep the assistant comfortable, and if intuition should not be acting on you, what you need is good counter traction, which you need to achieve one way or the other. The evolution 2 is we have divided this into a 2-part procedure instead of 1 part, restricting the peritoneal cuts instead of extensive cut of the peritoneum. We started cutting a window of it and then developing peritoneal flaps so that the flaps are elevated, and flaps automatically exteriorize, lateralize the bowel. And then we use graspers with bolsters and T-lifts, and then the endo loop. We developed it as a tent with a 5-point retraction. 3 instruments and 2 to 3 T-lifts are used. Sequential position and dissection, surgeon on the right side first and surgeon between the legs later on. The lower abdomen, lower para-aortic is done from the right side, upper abdomen from between the legs. And what is extremely important is to follow a protocol. The first thing that should be done is to carry the transverse colon and the omentum up into the upper abdomen, not under the liver, but preferably over the liver. Even if it is going to take some time, I think it's important to do this and get this bowel away. Otherwise, when we reviewed our old videos, the first videos, the bowel was looking so bruised, it really makes you feel very anxious till the patient actually gets discharged. And it can be a recipe for injuries. So it's important to push the bowel once, and if you can maintain that like that, these procedures become very, very easy. And then the peritoneal cut is commenced on the iliac bifurcation, and this cut does not extend up to the duodenum. Much below the duodenum, a window is opened, and under the peritoneum, we reach the ureter on the other side. As and when needed, small incremental cuts can be made But the essence of all this is to create a good window and create space so that you will have a wide space with peritoneal flaps that are developed. We should stay very patient while we do this. The right flap is being developed. And then the T-lift, I give all the credit for my learning of this, introduction of this. It's not a very long ago that I actually saw this. I never knew it. I met Dr. Prashant Mangeshkar and his son Abhishek Mangeshkar in Bangalore in a cadaveric workshop. All of us were as faculties, and I was surprised to see this. He was using it in the pelvis, but he gave me the address. He showed me how to use it, and it has helped my patients reduce an hour's time in these procedures. I take this opportunity, I hope he has logged in, to thank these two gentlemen for introducing this small, simple instrument to me. That is how they are. They never disturb the surgeon. They are lateralized. And once you do this, it works wonders. What we understood initially is it doesn't work like in the round ligament or on the uterus. It gets cut through. The T-lift is a thin thing. So and the peritoneum is also not very strong. So they were getting cut through like this. So we had to do something about it, because we can't be inserting the T-lift time and again while the peritoneum gets cut through. So what we started doing is used various things to buttress this. One of them was the Surgicel, but Surgicel does not have the tensile strength to stay intact always. So we started creating bolsters which are much cheaper, and then that's what actually pulls it wide and far, and throughout the procedure it just stays like that. We used sponges, we used various biosynthetic materials. One of them developed by our own R&D team is being used now. And then we have always seen our pioneers in surgery being good endosuturers. So initially itself, when you have a long sigmoid, I think it's important to stitch it laterally. We have used every instrument that was there. We have used a grasper from the hypogastric trocar for the IMA dissection, which is the most crucial dissection, the endo loop, the endo mini retractor, and many other things. The Sill Sports roticulating instruments were also used so that they don't disturb the left and right hand of the surgeon himself. The final aim of all this, what to use is may not be the most important, is to open up a tent like this. So minimal access keyhole surgery does not mean you operate in a keyhole inside. Outside it is keyhole, it's minimal access, but what you need is maximal exposure. I think you should not start resecting till you achieve this goal. Once you have a space like this, and what is important here is to pull this up, whether it is with T-lift or with instruments over gauze pieces or bolsters. What is important is to pull up this tent, not to push the root of the tent, but to pull the shoot of the tent. That is the trick. And if you do this, the small bowel doesn't come into it. And the resection actually is very, very simple. The first part holds the key, and first part is very crucial. And first part is the one which is much more difficult to learn, especially if you are not supported by a very good team. And then manipulating the space, I would discuss under these heads, riding along the gonadals, IMA and the paracolic aortic basin, the lymphatics, and the anatomical variations. Along the gonadals, both on the right and the left side, both these are done while the surgeon is on the right side. The ureters have to be under vision, both the ureters, and then keep the ureter away and then resect the rest of it. Keep its vascularity also away, the mesoureter away, and then the gonadals and the tissue around the gonadals are all dissected in a window that is created under the IMA. and the on the right side under the peritoneal flap that is developed. Once this is done, the T-lifts are brought into play, and then the surgeon shifts between the legs of the patient. And while the surgeon is on the right side, the inter-iliac harvesting is important, because the vein can be of variable caliber and distance from the artery. And what is also important is, especially in young patients, when you are doing staging lymphadenectomy in germ cell tumors or in ovarian cancers especially, it's important to preserve the autonomics, to preserve good sexual function. So when you do that, I think it's important to develop a window here and then do a good intra-iliac harvesting, while the nerves are retracted and preserved. Energy tools play a major role, because you would not want lateral thermal injury in this area. And then you proceed and do the rest of the dissection. The common iliac dissection is done from the same window. Som keeps talking about this. The midline split and roll is something that we use, and that is probably the best method of doing, the easiest method for both the beginner and the master. And this is done both in the while the surgeon is on the right side, and while the surgeon is on the between the legs also. As you learn, what happens is the major component of it gets done from the right side itself. The higher you can climb into the mid-abdomen from the right side, it makes things easy while you are doing the upper abdomen from between the legs. So the midline split and roll is something that works really well, because the aorta and the cava are displayed and preserved. The IMA dissection is also completed. And then you shift between the legs and continue this midline split and roll while preserving the sympathetics to a good intra-aortocaval clearance. Essentially, the technique is based on the IMA. To the right of IMA is a right-sided specimen. To the left of IMA is the left-sided specimen, which comes along with the left gonadal. Keep chipping and cutting here till you see the left renal vein. The upper limit would be the left renal vein. IMA is the key to dissection, and the para-aortic dissection is probably the most difficult, and that is the one which we took some time to learn, because the IMA comes in your way. Although it is said that the IMA can be clipped from its root without any serious consequence, but these are all elderly patients, obese patients. There can be a compromise of colonic vascularity. So we always prefer to preserve anatomy as far as possible. So it's important to skeletonize the root of the IMA and then proceed behind it, shift the packet into the supra-IMA compartment and continue the dissection. The most difficult part of the procedure, and this is something that I've learned after the first 30 procedures. The first 30 procedures were patients for whom we did we spared significant part of the para-aortic lymph nodes. So it was a journey wherein we were refining the technique, and we were actually expanding the horizons. That is the left gonadal that has been displayed. And then the gonadals have to be managed. Once again, place where there can be significant number of bleeds. The right gonadal and the left gonadal, both the gonadal arteries and veins are seen. can actually see the left gonadal here, right gonadal vein, right gonadal artery, and the left gonadal artery. I had never seen the gonadal arteries while I was an open surgeon. I always thought they are too small to be noticed. But as technology evolved, you have 3D and 4K technology, you cannot help but see this anatomy very, very clearly these days. So that's how you click both of them, the right gonadal at the cava and the left gonadal at the renal vein, and peel the tissue down and get it into the pelvis for the completion of the procedure from the pelvis. If you are done a para-aortic lymphadenectomy first, we do not clip the gonadal arteries. We routinely clip the gonadal veins. We do a sequential coagulation of the gonadal artery and use a clip because a vein may not respond to a coagulation. Initially, we would do a hysterectomy first, but when we decide upfront that para-aortic lymphadenectomy is necessary because of high-risk features, we have understood that it's always better to do the para-aortic lymphadenectomy first, because if there is a small bleed, especially in the pelvic spaces, what happens is these two videos wherein everything becomes dark in the upper abdomen. A good dissection done here, the gonadal is there, the IMA is seen, but things look very dark here, and for the beginner, it can be a little more uncomfortable. So if you can complete the para-aortic first, even if there is a small bleed there, you would have completed the most important and the most crucial part first. So you can actually see that the entire procedure was done pelvis first and then para-aortic. So now what we have done is to shift to para-aortic first, because you are fresh and you do the more difficult part first. While we continue to do this, we had a few problems. There were 2 lymph leaks, significant lymph leaks, I would say. There were a few other leaks also which were treated conservatively, but these leaks, one of them had 2.5 liters leaking every day for about 2 days, and then we decided to go back in a very obese patient, and then we went back laparoscopically. It can be this difficult. Patient must have swallowed air, and then the space that was there was so little, a doctor's mother. So we decided to endure this and complete it laparoscopically. We gave cream for this patient through the NG tube to highlight the lymphatic system, and you can actually see continuous leak of the lymph here. And while we visualize the lymphatic in the upper abdomen, very close to the renal veins, we had to suture it twice to control the lymph leak here. The other video is a patient who came back with chylous ascites 20 days after discharge. We had actually, the drain had got blocked. So what we did was, a 78-year-old lady, what we had to do was to reinsert the drain, and this patient actually settled conservatively. So one exploration and one patient who settled conservatively. This is when I met Somasekhar. We keep talking to each other in Jammu, where we went to do a workshop together, and we were in the same place, staying in the same place. So we had actually paused for a while. We were not doing lymphadenectomies because these 2 patients had a very, very difficult course in the hospital. So Somasekhar, as always, is extremely well read. So he was talking about the duodenal sweep of lymphatics. And this is something that I understood was very, very important. There is a leash of lymphatics that come down from the duodenum and the pancreas, crossing the left renal vein. Left nephrectomies induce lymph leaks much more often than the right nephrectomies, especially if you stay paracavally or para-aortic. The reason is this leash of lymphatics, which need to be addressed. They need to be clipped electively, not when they leak. These patients are fasting and are bowel prepped, so they don't leak on the table. They leak later on, much to the discomfort of the surgeon. So identify them, dissect free, and then clip them. You can actually see the renal vein, the intra-aortocaval dissection done. a leash of lymphatics that are coming down. You must take all the pains, and this is the reason why the left iliac fossa port has become a 10 mm port now, because we push the 10 mm hemlock clips through this and deliberately clip all these lymphatics. And from that day, in 2015, I think, we never had an exploration. I should thank Somasekhar, the moderator for this session, for this. I'm glad he's the moderator and he deserves to be so. Handling bleeds is much more difficult. Lymph time gives time. You can take your time to do this. And handling bulky adherent nodes was also something that was not easy. Anatomical variations are not uncommon in the retroperitoneum. An old video, what happens here is something that you must see. You don't have to do anything rash. What is important is to complete the cycle of coagulation before you actually try to tease the tissue. Teasing is something that should not be done. What is important is to keep the hand steady, coagulate once, twice, and then cut it in situ. If you avulse and tease, this is what happens. And not an easy situation, because you have just two hands there, and if the suction is in the right hand, the needle holder cannot come inside, and if you take the suction out, the blood keeps welling into, and what happens here is you have lost the visual completely. So what is important is, what we have learned by experience is to have a suction in the surgeon's left hand, or if you have a very able assistant, I think assistant should bring the suction there. Initial time when I was not the best endosuturer, fortunately for me, I tried a clip, and then with a suction in the left hand, because it's a dynamic suction is necessary, and then with the support of the first clip, I had to clip once again, and that is when I was lucky that there was a tangential clipping that has happened, and this is something that doesn't happen always. 3 other times we had to suture. So if you have to choose one thing, it's important to shift the suction into the left hand as soon as there is a bleed. And tie, you pick up a 5-0 prolin. One more trick that we have learned the hard way is to put a knot, not very close to the end, but a few centimeters away from the end, like this. Once you do that, you can actually pull the thread like this. Otherwise, what happens is, first time when I was suturing, while I pulled the thread came off from the vein. So I had to suture it all over again. So once you do this, because there are just 2 hands, and left hand can hold it and pull it up. And many times what we actually observe is that it would have stopped bleeding with that traction itself. So if you have a knot a little away from the tip will be there for you to suture. It was a significant bleed, much more recent video. We went inside, it was a gonadal that was bleeding. Went in there, and you can actually see that it's bleeding there. One burn there, and it actually stopped. You may not always be as lucky. What happens here, you see, the fellow veins are something that are very, very important. You can actually see a very small vein that I actually did not notice. I was dissecting in the upper space. This got avulsed, and it really bled significantly. These are things that should not be neglected. One trick is to increase the pressure to 20. We generally operate at 12. Increase the pressure to 20 to 25. That can decrease the bleeding significantly in some patients. And then what is also important, please do not try to grasp like this, because cava cannot be grasped by instruments. I shifted from a regular grasper to a Maryland's to no avail. What is important is to push a gauze piece over a suction and go in with a 5/0 suture. You don't have too many instruments there. You have only a suction, so you have to park the needle there. So you can see the knot there working well for the patient, and that is the other end, far away. So the left hand can hold it and lift it up while the surgeon takes the second bite. The assistant is doing the suction from the other side. It continues to bleed a little bit, but the bleed is much lesser. So a definite stitch underneath can be done if you can do this. Small trick, small addition, but can make a big difference in crisis and prevent conversions in these patients. Bulky adherent nodes. This patient had a bulky node in the pelvis. On the scans, we started with the Para-Aortic. We visualized the pelvic spaces. We used all the instruments that are available: a curved Maryland's force ligature, a straight ligature, a hook, a spatula, suction, blunt dissection. Not an easy game. Most of the time, even if there is extracapsular spread, there is a plane that is quite well maintained in these patients. Patients is something, this part of the procedure was done for about 20 minutes. But it's very heartening to understand that at the end of it, it ends up as a very good procedure. You shift to the left of the cava, work around the most adherent area. What is important is to dissect area around the most adherent so that you will have an access from all sides if there is an injury. And then the renal vein, the gonadal vein joining the cava is clipped, and it was embedded within the disease, so that could make it much more difficult. Eventually achieved a good clearance. We have seen quite a few anatomical variations, minor and major vessel variations, and organ variations. Each patient has some smaller major variation. The double gonadals that you keep seeing are very, very common. Arteries are less common, but veins are much more common on the right side than the left side. Need to be clipped separately, identified and clipped. Gonadal arteries need not be arising at the same level. Keep dissecting and then find that the gonadal artery is much higher. We have even seen a gonadal artery that was arising from the renal artery on the left side. On the left side especially, it can be much higher than you would have expected. Can be injured, can lead to bleeds. Gonadal arteries at the same level here. SMA is something that is important. Whenever you have multiple renals, you have to be very careful to understand that multiple renal vessels, especially on the right side, are associated sometimes with a very low SMA. We have even seen an SMA which was lower than the renal arteries. So 3 renal vessels for this patient with an SMA that is immediately above the renals. Something that you must keep in mind so that there will be less chance for an injury. Whenever you have a low renal, when you have done the upper part of the reticuloperitoneum first, always expect another polar vessel much below from the common iliac artery. And this is something that happens very, very regularly. We have seen it 3 times. You can see this, and then you always find that the renal is also very, very low. And if you clamp and cut this, a significant polar vessel would have been lost for this patient. You can see this patient here. We dissected the upper part first and understood that the right renal was much below the renal vein. Renal vein is here, the right renal is here, the left renal is here. So we were expecting this renal artery to be abnormal. Post-operatively, we did this CT scan in retrospect, actually, after doing this dissection, because we wanted a good view. And you can actually see that this was very clearly seen in the volume rendering phase of the scan. All these anomalies were actually seen. I compliment Srajan, our consultant, for learning this and actually teaching and training our own radiologists how to use the 128 slice CT scanner. Truly appreciate this boy for this good work. You can actually see that the gonadal artery is arising from the lower renal, the accessory renal artery that is arising from the aorta at the level of the IMA. Can be injured very, very easily if you are not wary of it. We started doing the volume rendering upfront and keeping it in the operation room. And that is how we actually diagnosed this double cava. Not an easy dissection. The renal is joining there, and you'll have to do a bilateral paracaval dissection instead of 2 intra-aortocaval dissections. Nobody would pay you double the money for this, but you will have to work very hard on these patients. Something that was very, very clearly visible. The radiologists and our boys understood that this patient needs much more time to complete. So we were all prepared the previous day itself. And then you can have a horseshoe in a patient with endometrial cancer. Once again, volume rendering scan done to understand how it was. There was no serious vascularity between the two, but we didn't want to cut the isthmus and go there. It was quite challenging because the isthmus was actually coming in the way of our instruments. Our instruments, the axis is tangential axis. You don't have a apex to floor axis, so it was not easy at all. So we went behind, and the IMA was like a hammock on the isthmus. So it was quite a challenge to do the intra-aortic cable and the supra-IMA dissection as a part of para-aortic lymphadenectomy. Aortic and iliac anatomy is complex. Aorta crosses the iliac, cava has its own tributaries that cross. This is something that this picture was something that added lots of romanticism. The surgery that involves this also is extremely romantic, only if you learn it well, and it is much more exciting and with an adrenaline surge when you have a situation like this, a patient with situs inversus totalis who has come to us for this surgery. We have done a volume rendering scan and understood the vascularity well in advance, and the evidence that it was truly situs is this. We had to really orient ourselves the previous day. We never did a lymphadenectomy like this in a situs patient, and the duodenum is on the right side here. You can see the DJ flexor there, the fundus there, the right lobe of the liver, the spleen that is hiding there on the right side, the spleen there. And the gallbladder on the left side. And while we dissected this, the IMA on the right side the gonadals here, both gonadals were joining, the right gonadal was joining the renal vein, just a mirror image of the regular patient, and the left gonadal was joining the cava very close to the renal vein, but not into the renal vein. Something that really tested our endurance because patient was obese, small bowel was continuously getting into the mid-abdomen. All this is something that needs to be done for a while till fluorescence imaging or sentinel node becomes firmly established. We have brought this system and we start doing fluorescence guided surgery now, which has become much more extensive. We use the sentinel concept and then inject into the lymph node, the bilateral groin lymph nodes to isolate the lymph nodes, and while the infrared camera shows us the sentinel, the white light shows us the actual anatomy, and in multiple modes, we keep seeing the nodes. This is the pelvis, this is the intra-iliac dissection, and this is the retro-IMA dissection. Everything ICG based. ICG seems to be the technique of choice now. We have used blue dye, we have used radioisotope, but I think what would stay is ICG, and with the newer dyes that are fluorescent dyes that are coming into market, I think this is something that will become a standard of care. And if that happens, and if para-aortic lymphadenectomy as a staging procedure is replaced, we would only be very, very happy about it for the patients. But I think till then, I think the youngsters should learn to do this procedure. It's all stay at home messages now. All of you are at home, cozy in your rooms. This procedure is a test of teamwork and endurance of the entire team. What is important is to chip and chisel and never clamp and cut, because there are retroperitoneum is a minefield. Each inch you move, you can step onto a mine. So you should be equipped fully. You should be a big team like this, and you should be equipped to the last tooth to handle these situations. Technique standardization is important so that it becomes easily reproducible. And then you must embrace new technology and use the time-tested minimal access principles. Never take anatomy for granted. After all, it is the art of unfurling anatomy is surgery with a bit of common sense. Clipping lymphatics, small or big, is important. You must extrapolate from other surgical brethren and learn from them, exchange skills to decrease the anxiety and difficulty of the procedure. It's important not to stay anxious and think that it is difficult. That is when the actual benefit that is extended to the patient comes down among individuals and the institutions. The benefit of staging to a wider population is only when we learn it systematically and develop teams so that these procedures can be done. And we have a very robust team, 50 of us working relentlessly, and all of them stay in one voice, and that voice is of the junior most resident, and that keeps changing because the juniors keep becoming seniors. And what the photograph that is hiding behind this is of the anesthesia team, the hidden heroes. They endure not the patients alone, but the surgical team also. We operate and they look after. A tribute to them. And when there is a problem, when there is no problem, all of us stay in a huddle. None of us is seen here, but all of us as a team perform well in this great institute, a 550-bed exclusive cancer care facility, doing about 7,000 procedures annually, about 650 per month. A tribute to all of them, and a tribute to all those who have stayed with me, who have taught me, and who have actually learned from me and encouraged me to continue to do this, add small tricks and stay young in this ecosystem. Thank you very much, Baiju. Thank you very much, all the leading lights of surgery who have logged in from across the globe. I am overwhelmed, and I will preserve this day for posterity. Thank you very much. Good night, good day.
Thank you very much, Subbu sir. It's like a God made, day one of the world, and we are unveiling actually the genesis. So it's like outstanding presentation. Compilation of the videos is, the first thing is you must write a operative atlas of Dr. T.S. Rao, which would be a super hit one, collection of all the rare anomalies and technical difficulty to, like how you manage. So like basics to advanced, training to an experienced surgeon. So that should be the title of your operative atlas. What a fantastic presentation. Number one is your journey, how you indigenously developed the technique and Indianized it. Then how you managed it for the difficult anatomy, difficult. See, most of the presentation people show their best videos, easy video on a thin patient. All your videos are one on a very tough patient, high BMI, bulky nodes, adherent nodes, and very difficult anatomy inside and outside. That's hats off to you. It is super. And if you see all the congratulatory messages that are coming in chat backs, that itself is evident. We need to just print out and make a book and then give it to you over weekend. You should really sit and read with your family and loved ones. That says the whole story. I really thank Baiju and then the SENADHIPAN Foundation to having found a fantastic speaker, par excellence, teacher of teacher, mentors to mentors, and an excellent topic and the way he covered. I really feel suddenly like, it really got over very fast. I wish it keeps going. It is one of those things, you finished your MBBS, last day, you don't want to leave the institute and your friends and go off. You just somehow want it to continue. You feel a part of your heart is really like out. So this is one of those feeling very sad that, I really wish it could have gone on and on and on, and it never had come to an end. We always say good things has to come to an end, but I wish this is one good thing which it has never come to an end. It's an outstanding presentation. It's a work which must be put it in an operative atlas and a book, which will be the best educative material across the world, sir. Fantastic. It's honor to preside over this. Thank you very much. What I'm going to do now.
One word, Dr. Somasekhar. Yeah, what a fantastic presentation. Actually, I have the same feeling as Dr. Somasekhar has mentioned. As Dr. Bandhubarali has rightly mentioned, you should have made a statutory warning on the screen that this is not for the beginners.
No, the very purpose is lot of beginners can pick up. See, the beautiful thing about Subbu sir is a beginner can also pick up the technique. These techniques are not only made to terrorize you, scare you that you don't do and only all the patients go to him. He makes it so simple, both for beginners and also for people who have been doing. There is a tip for this.
And he has shown the rarest of the rare videos, even situs inverses, everything so well. I think there are a lot of questions from the audience to keep the ball rolling. Just let me ask you one question. What is the IVC pressure you keep, or you ask anesthetist to keep while you start the dissection first?
Pneumoperitoneum, you mean?
No, IVC pressure.
Oh, really?
Actually, what is the CVP you would prefer to?
CVP.
Honestly, we don't bother too much about it.
No, because most of the videos I saw, except for the last two videos, the IVC pressure was high, feeling high, and probably that is the reason why that bleeding was there. And when it collapsed, yeah.
See, now I've started learning now. I never bothered about it. To be very honest, I've never asked the anesthetist to keep it low. No.
Actually, Baiju, that's an excellent thing. Yeah. One of the 7 cardinal things which I also tell everybody is, before I do a para-aortic lymph node dissection, minimal access, I take my anesthetist for a cup of coffee. And I tell him very clearly, either you can make my life miserable and give a biconvex distended vena cava. I keep working on for 2 hours and you keep giving anesthesia with me and I keep oozing and then I keep controlling, or you can collapse the vena cava and biconvex you can make it flat and we all go home happily very fast. So that's one of the tips, one of the few important tips in RPLD which we always tell is that the venous bleeding is a high volume, low pressure. Always address it. It is like your mother-in-law, don't ignore that. For you, you think hardly any blood has come, but in short time, it loses lot of blood and there is a hypotension and hemodynamical instability happen with venous. On the contrary, arterial bleeding is high pressure, very low volume. It makes a mess and it terrorizes you. At the end of it, it is very little ml and no hemodynamic abnormality. One of the most important in para-aortic is to have a collapsed IVC all the time and low hydration around that time.
Liver resections, we ask when you do liver resections, we ask the anesthetist to keep the CVP pressure less than 5. That's what I asked, because most of the videos he showed, except for the last two, the IVC pressure was high. That's why I asked.
Yeah.
I'll do the next procedure much better than Baiju.
That's see what I have done is I have noted down all the questions and the leading doctors who have asked those questions, which now we divide the discussion into two parts. One part is all the questions Subbu sir can't go unless we answer it, because people have put there and I've noted down, and the person who was asked, I'm going to ask that. And before that, there are a couple of other questions which he needs to sort of, we take his expert advice. Number one, we would like to really, take from you is, what is your opinion about laparoscopic transperitoneal and retroperitoneal approach to RPL? What have you tried the retroperitoneal? What is your message to beginners? You would say learn both, or you would prefer one? Is there any tips from your vast experience you can give to everybody?
All the retroperitoneal work that I have seen, I was always very uncomfortable, because the best position for retroperitoneal is prone position. It can be a lateral tilt and you can do it, but I've always understood that the contralateral side, the right side dissection becomes inadequate if the patient is in supine position or lateral position. In prone position is a good position, there's no doubt about it. But changing the position and completing the para-aortic lymphadenectomy, and if there is a bleed or if there is a problem like that, it becomes a much more difficult exercise for the patient. So somehow, without even trying, I didn't develop a liking for the extraperitoneal approach. And we have always understood that the most obese patient can be tackled with, if all these tricks are used, transperitoneally. So right now, we keep the patient in one position and don't change the position at all. The surgeon changes position, but the patient doesn't change position at all. Patient is in Allen stirrups, legs split from the beginning, and the surgeon stays on the right side. The whole team rotates 45 degrees and completes the procedure. So I feel we have mastered one. I didn't want to try the other one at all. I don't know if anybody has an experience of the extraperitoneal in India.
Yeah, that's true. To address this particular issue, like I think when me and Nirja went to Mayo Clinic Rochester for gynae onco, we saw the Mayo Clinic group does the retroperitoneal. One of the issue that they told is to do the pelvic part transperitoneal, which is easy. The whole issue of para-aortic is the bowel falling down mesentery, and then 90% of the time is sort of exposing that area, and the left renal vein fork node, which is the most important node on the left side, is little difficult to tackle in that. So one of the reason was the Kohler, Dargent and Dowdy team actually developed the retroperitoneal. Do everything transperitoneal, then give a little tilt with a sandbag, and then you go from retroperitoneum, and the gas would lift the mesentery. Then you are not seeing anything other than the psoas, gonadal, ureter, and aorta and vena cava. It would be interesting to let the audience that there was a trial which looked at total transperitoneal, like what Subbu sir showed just now, and bilateral extraperitoneal and only left extraperitoneal. There is a beautiful 3 studies which are published, and also there was a GOG study which compared this. They found that all the 3 techniques are equal as far as the yield outcome is concerned. Only in extreme high BMI, like the one in US and UK, you see very high BMI patients, and patient who needs radiation later, the adhesions was very low. So these 2 score. There are actually 4 studies which looked at all the 3, but it is ultimately individual preference. The way Subbu sir showed, the way you can expose with the tricks, T-lift and everything, it's fantastic. So there are all the 3 techniques. Some people find it easy in high BMI and radiation requirement patient, but all the three are fine. That's something good.
In between, while you read out the questions, in between you can ask stalwarts like Dr. Palalivedu to open their video and give their comments regarding this presentation as well as their techniques.
Exactly. Palnivelu sir, you can definitely go ahead and do that and give any tips and tricks. Anybody in the group does the retroperitoneal or any other approach? I've always seen everybody doing transperitoneal only. Europeans actually are very popular in doing retroperitoneal, and Memorians, Long Kettering, and Dargin group, and Kohlers and Dodig group does retroperitoneal. Any Subbu sir, I want you to give certain tips. You already covered most of it in your talks, but while doing a dissection in aorta vena cava area, if there is a bleeding, can you give five cardinal for beginners? Because most of the questions in the chat box is how do we tackle the bleeding? So what is that 5 things you would say the moment you notice a bleeding while doing dissection in aorta vena cava area you want?
Alert the anesthetist first. Minimal access, that happens automatically because they keep seeing the screen. You don't have to tell them. So alert the anesthetist, increase the pneumoperitoneum to 20. And then what is important is not to hold the bleeding site, not to try and grasp anything, because even a vascular clamp cannot stop these bleeds easily. And if you push a vascular clamp, what happens is one of the important ports gets consumed. And once you clamp it, you will have to move to the other port, and that is where the bowel is kept away or the tent is maintained. So it's important to get a suction into the left hand, push a good gauze piece inside, apply pressure with the right hand on the gauze piece, get the suction inside. Generally, suction is on the right side, so shift it to the left side, and then get the suction onto the gauze piece. Get a 50 prolene knotted away from the end, 2-3 knots, and then transfer it into the abdomen. Press the gauze piece with the suction while you are sucking, so that the field stays clean. The pressure is applied by the gauze piece and the suction keeps it clean. And then take a bite, roll the gauze piece down slowly. You see the injury, and then take the first bite, and the knot holds the cava up. Take the second bite, put a figure of 8, and each time, without any serious bleed, this one stops. This protocol is something that we had to learn the hard way. We had 5 or 6 bleeds. Only the 5th time we did it so well. If you could do it the first time, I'll be very happy with it.
Fantastic. I see that, Giri is there. I would invite comment from Palnivelu sir, SK Giri, and also Chandramohan. Is there any technical tips or things you want to share with your experience pertaining to para-aortic lymph node dissection?
Yeah. Yes, Somasekhar, I think it is a very nice talk, Rao. Yes, Rao, I enjoyed your talk. You've shown every possible problems also during your videos. It is mostly, as Som put in, people do always show the best of this and take it credit, applause and go. Today, Rao put in every problems also put in, and various anomaly. I don't know how this guy got it. Very rare, no? Something is unusual. And this is only luck, but it must be there. They got it. You got very nice. I enjoyed it, your talk and everything. And I think this is one of the complex, and as Som already in the introduction, he said it is a para-aortic lymphadenectomy. It is a technically very sound, very important thing. Each one has developed his own way approaching it. And our approach is we don't shift from right or left, and we go in between the leg operate. And that way we dissect starts from the between the pre-sacral nodes and go aortic and go blocked by completely take it down. I demonstrated, I don't know whether you all seen or not, my own bowel retraction technique I described using a rubber band. And I use it for wherever possible that way. And no instruments will be coming in my retraction, whether it is obese, BMI more or thinner. And entire mesentery will be lifted up towards laterally. and left side colon to this, rest of the small bowel. The entire mesentery will be lifted up when you go, once you make a cut in front. And that is, I think, this time, I think I will describe later, I will show, demonstrate. 3 years before also, I showed the same thing technique in robotic also, and Para-Aortic lymphadenectomy, I demonstrated the rubber band technique. More than readinectomy, everybody is looking at band technique only. Oh, it looks nice, looks nice. No single instrument will come anywhere in the bowel to support it. That is my own technique, described it looks. And I think it is vessels you nicely don't. I think one can keep it no, like a liver surgery anywhere, any oozing is there, we'll always anti-fibrillar, no, like a gel foam, there is a different kind. Put it there, few minutes, wait, most smaller leak blood stops. We cannot go and compress it. Gas piece is one is very difficult to all the time, compress. As you said, the anesthetist support to be a very strong supportive. And the vascular clamp, we cannot at that time go and use it, it makes injury. But prepared, any nodes adherent to the IVC, that time they can prepare, oh, this may give a trouble. So what you can have a loop down and above, then you can dissect working it. Even the injury happens, no problem. There can be loop, or you can give a bulldog clamp across and give it. There is a vascular clamp, it is not occluding the IVC fully. It is partially, you can occlude, you can go on, cut it, and even suturing repair can be done. That is the way certain things are described, it can be. But I know, as you described, I have not done retro. I have not seen, and that is, I am all comfortable with the transperitoneal as Rao put in, always all the close go. And I think this is one thing we all should discuss once in a standardized technique. Today, Rao has done the maximum standardization. We can we can join him giving it. It is nice. Thanks, Rao. I appreciate it. It's a good meeting. I enjoyed it. Any other suggestion, other people comes, I'll be part of this.
Absolutely. Then thank you. Fantastic.
And I take this opportunity. I think this live surgery, we are going to have it in Somasekhar coming November 20th. Gynae, and we are showing Para-Aortic lymphadenectomy live is going to be there, and I want all of you to be there. I will send a letter invitation to be part of this meeting, and you all have it there. Somasekhar in India, we can. I'll send the program to all of you.
We'll see your rubber band, sir.
You have seen, huh?
I've not seen. I've heard you speak, but you have not shared that, sir. You have kept it a secret. That is my complaint about that.
Hey, demonstration live I showed.
In recent CRSA and all is this one. Lot of us have picked up the rubber band technique.
3 years before I showed a live surgery with the rubber band technique.
I missed it, sir.
Even last month CRSA, lot of rubber band.
You people ignore me as a gastrosurgeon. That's why I have not seen that time.
Actually, Pandivelu sir's rubber band technique, most of the robotic liver transplant surgeons in India picked up. The Amrita Institute, even at Manipal Hospital, our robotic liver transplant team, they all picked up that same rubber band technique. There are actually 4 or 5 ways. One is what Subbu sir told, T-lift. Second thing is the rubber band. Now I have switched over to a Versa band. I got it since a year. Versa band is just a straight needle with a ethibond with a pichet, and the thing in T-lift is you can put it easily, and if something happens, you need to rework. Little bit time goes on for readjusting. In Versa band, it's about roughly 7,000 rupees per Versa band, and it's reusable many times. It is just a needle which comes with a pachet and a small silicone strip, which I now totally have switched over to that. But this rubber band technique is very good. In rubber band, you need to suture on one end and then pull it on the other end. But in Versa band, you just pass a needle and rework as many times you can put up. But there are more than one right way.
So the difference between this Versa and this one is a dynamic retraction. Correct. As you dissect, the rubber band will go on retracting it outside. It Correct. Gives us more space increase by itself. If you are not increasing it otherwise, it Correct. Makes it sure.
Counter traction comes automatically.
It increases the space. Yeah. I do it like everywhere, wherever most of the places.
It's an extremely good technique. And tissue will never tear. One good thing in rubber band I noticed is tissue never tears. The mesenteric end and the bowel always holds. It never tears.
No.
Yeah. Thank you very much for your insight, sir. I will invite SK Giri. Giri is our very senior gynae onco and past president of Agoy, great friend of Subbu and me. Giri, I would invite you the comments on what Subbu sir told, and is there anything you want to give your inputs? You want to give your comments on that, SK Giri? Giri, you can unmute yourself. Baichu, can we unmute Sushil Giri?
Sushil Giri.
Yeah. Dr. ISK Giri, Sushil Kumar Giri. Yeah.
Yeah, we asked. Dr. Sushil Giri?
Yeah, you can raise hand in the, yeah, yes.
Thank you.
Are we able to unmute him?
Yeah, actually we unmuted, but he's getting muted again and again.
Can I unmute? No, I think I can't.
You are also.
His wife must be around, so he's getting muted again.
Until that, Sarika Gupta has put a lot of her. Giri. Yeah, Giri, please go ahead.
Yeah.
Good evening, Giri sir.
Thank you for allowing me to listen to all these videos and all this etc. of yours.
Your internet is unstable, Giri sir.
Giri, at your end, yeah.
And those who are able to speak, anomalies, all these things. Yes, in anomalies, lot of anomalies we have never seen. Usually, it is not. With 30 years of practice, we have never seen so much of anomalies in patients of in the radical surgery. Hardly we have seen some arteries or some Moderator, all these things. And now it visually observing from I logged in around 7:30, and I'm waiting X-rays to listen to and to see the videos of the work. And his comment was really listen to it. Thank you very much for alerting me in this really video festival, I can say. Thank you very much.
Thank you. I would invite Ayyappan because Ayyappan is somebody, is an excellent minimal access laparoscopic surgeon, and his area of interest in addition to HIPEC is gynae onco and colorectal. So he has a vast experience in a high volume institute in Adair before he moved to his center. So Ayyappan, can you unmute and then, can you just give comment on the videos Subbu showed and any of your input and any other way you would do it, or you can give a tips? Ayyappan?
Yeah, I am there. Soms.
Welcome.
Soms, thank you for this.
Before that, what is the secret of this? You are keeping in this youth.
Multiple girlfriends.
My God, Soms, not here, Soms. And that is not the fact at all. I think we should follow what Subramanyeshwar Rao is doing, daily exercise, I think, and genetics also plays a role. That's all. Now, going to Rao's talk, it was amazing. So 2-3 things I thought I should add on to that. The first thing what I thought was, we have not been using the T-lift or whatever others are using. We just used the left hypogastric one port. We used to hold on to the flap, whatever we raise, and then use one arm to totally lift the whole thing. It's a sweep technique. That's what we have been using. But many a time, if it is going to be high BMI patient, we find it very difficult. But somehow we manage. The next thing what we thought was, follow whatever you do on your open technique for arresting the bleeds. As all of us have put, we just put a gauze piece there in that area. That's the most important thing. We try to have a bipolar also with us. And open technique, we use the bipolar many a time when we're doing the para-aortic and the para-cavern dissection. And with the bipolar, many a time it stops. And we have not had the opportunity of taking a stitch so far, a Pfizer, and that is the knot technique is an excellent one. Taking some 2 knots before that at the end of the suture material, that is a very good thing. And the initial days, we were doing the retroperitoneal approach. And the retroperitoneal approach for a high BMI patient is amazing. These are the things which, because Eric LeBlanc, the man who started off with that is where I got trained under him. And his technique is always a retroperitoneal approach from the left side, you know. As he told, the right side becomes difficult to handle the whole thing. And today, I need to say, Beju, you chose a very good speaker and an amazing moderator also. The pair was something extraordinary. I need to thank you for that. And I thank the opportunity which has been given to me also. Thank you.
Thank you, Ayyappan. You know, what you told about Eric LeBlanc is absolutely right. I watched him about 10 years back. And when I went to Mayo Clinic, Sean Doherty learned from Eric LeBlanc. What you find in retroperitoneal approach is about 45 minutes, the whole para-aortic happens. And the way you're tuned in laparoscopy, where the vena cava, aorta, and then the psoas are running parallelly, you would see them in a side view running like a canal, rather than in open, we work from above. But in laparoscopy, we are tuned to turning the camera and seeing all of them tangentially. So then it doesn't matter how much patient obeys. That's a good technique. I would really see experienced people like Subbu sir, if he goes to retroperitoneal, he will master it. You know, it's just like 1 second he can do it off. The trial does show that all of them are same in the lymph node yield, but in high BMI patient, and if the node is positive and a patient needs a radiation, the retroperitoneal technique has it. But having said that, all of them are actually exactly same. All of them are same to same. So what I would do is I will now throw some questions to Subbu sir from the chat box, because a lot of people have asked a lot of important questions, and we need to really go ahead for this and then take care of this. First is Dr. Lakshmikant has asked, it is quite obvious, Subbu sir, when he use ligation. Why not harmonic? You know, most of the gynec oncos start off with harmonic. That is their friend. But then we become wise. We understand the most dangerous instrument is the vibrating, oscillating harmonic jaw, which human eyes cannot see. The damage is from later. And it is a good dissector, but not a good sealant. But this question is from Lakshmikant sir. Why? What is your take on why ligation are not harmonic? Is it like harmonic no, or you would use the para-aortic through the energy device?
Close to vessels, I'm not comfortable with a harmonic, because of the simple reason that what can touch the vessel is only one arm of the harmonic of the instrument. The other arm cannot be anywhere close. And what is much more important is I don't want the tip to be active, because I'm not trying to resect here. I don't want the tip to be active. So that way, it really suits my needs. And initial part of the training, I've been a trainer all through. While I was learning, also I was a trainer. Whatever injuries were there, they were all induced by the active jaw, which got in touch with one of these vessels or other structures. So harmonic, if the surgeon is not an expert, harmonic is much more dangerous than ligature. Ligature has its problems, but it seems to be much more safer, because all the damage is between the jaws and after you clamp. So I find it much more safer. Looks a little more clumsier. This looks much more stylish, but when it comes to safety, I think ligature is better.
Absolutely, I fully agree with you and endorse that, because here we don't want a major dissection. Dissection will be done with other instruments. The sealing should be very safe. There is another question from yes, please go ahead.
Dr. Paraniveli wanted to give another comment, I think. Sir, can you please open?
Please go ahead.
Rao, we had one of the patients that uterus, they didn't remove it, and they removed para-aortic ovarian carcinoma. And that lady subsequently conceived and even second carry. What is your comment on this? And it is stage 1A we have done. And I think from an onco point of view, Somasekhar and Rao can comment on this.
That particularly is, if you operate, they remain fertile also.
No. No, lady married, came back after 2 years without issue.
Then it is, we thought it is better, we did it. Now completely, it is now 5 years over, 4.5 years over, the patient is doing well. Conceived baby now 3 years old.
Sir, that is a tribute to oncology in all its expanse today, sir. Quality of life indices, very important quality of life index is fertility. There was a webinar yesterday, I suppose, or day before, on fertility issues in surgical oncology run by IASO. So it only underlines the importance of fertility. So cancer patients can become mothers, can become fathers. So that's where we have reached, and I think attention to detail and attention to not only to survival, but survival with great quality of life is important, and that's what you have done, and we always appreciate for everything that you do. Thank you very much, sir, for sharing that.
And what you asked is absolutely right. Suppose you have a stage 1A endometrioid adenocarcinoma endometrium, or stage 1A, 1B ovarian cancer, or germ cell tumor. You do a systematic laparoscopic or whatever staging you have done, but fertility preservation will have a same oncological outcome as others, and still fertility is preserved. But provided they are 1A endometrioid variety of endometrial CA, and 1A, 1B ovarian CA, and germ cell tumor, in all the rule is fertility. You're absolutely right. Sir, I have one most important question which lot of people have put in chat box. I know that me and Subbu many times have discussed this and worked out on that, but for the sake of audience, can you summarize what are the complications you might encounter in para-aortic? Because most of the questions are pertaining to lymphocyte, Tylor ascites, bleeding, how do you handle? So in your experience of this 100 cases, can you sort of enlist what was the major complication in which order? Like if you want to take 10 complications which you keep, then it had to be a complication of surgical technique. Every surgery has its share of known limitations or you need to watch for. What are the 10 things in your series you would put it in that order, and if you can say what you did for a message of people? Because it is the management of this complication that is more important, which gives confidence for people to go ahead.
We had about 5 or 6 small but significant bleeds of the cava. 5 or 6, I think it is 6. And all of them were sutured. Some of them were clipped, 2 of them were clipped, the rest of them were sutured. One of them lost blood significantly. And one conversion had to be done. That was in 2013. One conversion, because I was not a great endosuturer then, and the anesthetist was anxious. So just the next common complication was we converted and we sutured. It was very easy after that. Not a very obese patient, but we had to convert. I would have wanted to show that video also, but somehow while we were finalizing, it got missed out. Next time I'll show you that, what had happened and why we had to convert. The next common problem was a lymph leak. We didn't have port site injuries, fortunately. Port site injuries can happen, and instrument injuries can happen, but nothing of that sort. The lymph leaks were there. 2 of the patients, one patient needed a drain only. Other patient we had to go back in and suture, and that patient actually settled down. Nothing else. So basically 102 patients, 2 conversions, one for lymph leak. Lymph leak actually was sutured on table, but we were a little worried because there was a small trickle that was coming from above. When we opened, there was nothing there. So we opened and closed. We didn't do anything inside after that intervention, but ultimately there were two conversions in 102 patients, and that was before 2015. In these 5 years, absolutely no conversions. 85 patients, 5 years, no conversions.
Superb, sir. Fantastic. Did any of your patient in long term have lower limb lymphedema, which is a sequel of an aggressive retroperitoneal lymphodissection?
Not as yet. We have them in fact, I have 2 patients with cervical cancer, pelvic lymphadenectomy, because they have been irradiated, real grotesque lymphedema, not in endometrial cancer, because I don't know, most of these patients do not need radiation. Once you irradiate, that's when it becomes a serious problem.
Absolutely. That's fantastic. For the benefit of students who are logged in, what Subbu sir told, these are the known thing which you keep in mind. One is bleeding vascular injury. Subbu sir already told how to do it. Most important is trend lumbar position, low hydration during para-aortic, low CVP, vena cava should be collapsed. Never start a para-aortic if vena cava is distended, biconvex. It takes more time, more blood loss, and spend more time on suturing. And then position, then use proper T-lift, Versa band or suture rubber band so you have a good exposure. Park a retake gauze, better to, I told you know, there are two types of surgeons. One who has kept a gauze, another one who wished he had kept a gauze inside the abdomen before he started a surgery. So you fall into category of first surgeon. Have a gauze, not use it, and not have a gauze when you need to use it. Take my word, many times that is the only line between open and conversion in a minimal access. And then keep a good bipolar. Subbu sir always tells this, he didn't reiterate today, when there is a bleeding, keep a gauze for some time, wait for 2 clotting time, go back there. Either it has stopped so you can easily suture it, or most of the time it might have. So 2 clotting time, go have a cup of coffee and come back with a gauze pressure there. So these 9 points are very important, and look for Fellows vein, 2 Fellows vein, one inch above the right common iliac vein, another 1 inch above from the anterior surface of the vena cava. These are very, very important 5 points. Second is lymphocyl, sir. Did you have any lymphocyl? Because we know in a literature of RPLND, like when we audited our 200 patients of para-aortic for publication, you know that lymphocyl will develop in 100% of the patient. You don't have to look for it. But symptomatic lymphocyl, did you have in your group, and what you need to do to tackle them?
We had it in, while we actually did routine scans, we saw 3 lymphocyls, not large ones, and we didn't do anything about it. Patient was asymptomatic. We reassured the patient, and patient actually started becoming symptomatic after the scan. So, but we had a psoas abscess actually in one patient, and that patient needed to be pigtailed, and it settled down. We should understand that it must have been a lymphocyl which got infected. In retrospect, that is the assumption, but we really don't know. And it was a non-specific abscess, not a tuberculous abscess.
So it's very important for everybody to know that lymphocyl happen in 100%, but you don't have to bother. Don't reperitonealize. 6% is the incidence of lymphocyl in para-aortic, but symptomatic is less than that. And most common is on the left side, just around the area of common iliac. We don't know why, but all the literature in the world has seen the symptomatic lymphocyl which required a pigtail or a aspiration is always on the left lower part around the common iliac. Now coming to Sir Kailash ascites, lot of people have asked a lot of questions. You know, Dr. Yoga Nagendra has asked.
Yeah, Dr. Palani.
Yes, sir.
No, same. Kailash seal only. Ascites, you go ahead.
Yes,
same what I will suggest.
Yeah, in the chat box, Dr. Yoga Nagendra, actually many people have asked about it, but in detail, Dr. Yoga has written, sir, in your series, how many had lymph leaks, how many had Kailash ascites, and isn't it true that because you create a lot of raw area, eventually they all heal with fibrosis, so they don't have to intervene? Really, it required. I request Subbu sir to spend little time and update all of us with his experience, because this is very, very important for everybody to know. So can you please elaborate on that?
I think chyle leak, lymph leak is all right, but once it becomes a chyle leak, it's one of the most dreadful complications, especially if you are not as fortunate as Somasekhar. Meaning, if you don't have a radiologist to intervene and block these, I think it's a very, very difficult complication, because you have done a minimal access surgery, and if you do a laparotomy, it will be a huge laparotomy in a very obese patient, and it's not something that you can promise yourself or the patient that you will come out successfully. Chyle leaks, even today, if they are not addressed properly, if they cannot be surgically managed, major chyle leaks, 25% is the mortality. We must understand this, and what is important is never to shy away from using any number of clips to actually prevent a chyle leak. For the past 5 years, we are so much more comfortable, so much more confident about chyle leaks. Chylous ascites is something that we have seen only in one patient, because that patient, the drain must have got blocked. And when we reinsert the drain from the next day onwards, because after 3 weeks, if the patient had a 3-liter chyle, which means it must have been leaking 200 ml, 250 ml per day only. So with that understanding, we just put a tube back, and that patient settled down. Now I think it is the 6th or 7th year, and she's doing well. So long-term morbidity, unless the patient requires radiation, is not something that should play too much on your mind while you are doing these para-aortic lymphadenectomies. Bleeds should not worry you, because bleeds can be tackled if you have a good nimble fingers, and if you are a good endosuturer especially. I think all bleeds can be stopped. And so what Som elaborated is very relevant. Talk to the anesthetist, ask them to do what they are supposed to do. Push a gauze piece, keep a gauze piece already inside. Apply pressure, wait for 2 clotting times. So that problem can be tackled. Chyle leak, please prevent it. Otherwise, I think you need to be a much better surgeon than yourself if you have to handle it minimal access, because patient would be post-operative in ILS, and bowels are not prepared. Bowel will be much more distended with gas and fluid, and your minimal access will be, and edematous, the chance for injury of the bowel or further injuries, the secondary injuries, and further increase in chyle leak is a possibility. And there are mortalities reported in chyle leaks even today. So I think it's better they are prevented. And what is important is the duodenal sweep. What runs from the duodenum onto the left side and in the midline, those lymphatics have to be electively clipped. Each time, every time, even if you don't find too many lymphatics there, they will appear once the patient is on oral fluids and food. So clip that area, areolar tissue, lymphatic tissue. Don't search for lymphatics. Clip that area if you want to avoid 90% of the lymph leaks.
Okay, Dr. Aravind Kumar Jain, you were mentioning about him before. Robotic surgeon from Gangaram, who was retired professor from AIMS. He has joined. Sir, can you please unmute your mic?
Hi, sir. How are you? Welcome, sir.
Good evening, Bhaiya.
Good evening. Welcome.
Good evening. I have been listening to this New York Philharmonic Orchestra since 8 p.m. And the best thing I could have done was to just keep shut and enjoy the music. Every time Subbu speaks, Somasekhar speaks, Palani speaks, and other people speak, it's part of Philharmonic Orchestra. So I have really enjoyed Dr. Subramanyeshwar. I must tell you, it was one of the best presentations I've heard in the last 25 years. Solid science, solid experience, no exaggeration. A lot of times, people try to exaggerate things. People try to hide the complications and present as if it's very simple. You have shown that it's a difficult thing, but a master like you can not only master it, but also present it in a very simple, easy to understand manner, at the same time highlighting that it's difficult and a lot of precautions need to be taken. So truly an inspiration and a truly teaching kind of presentation. I think the SENADHIPAN Foundation should be really grateful to you. And I'm sure all the listeners would have enjoyed immensely. Hats off to you, Dr. Subramanyeshwar. Hats off to you, Somasekhar, Dr. Palani, and Dr. Baiju SENADHIPAN. Thank you.
Yeah. So
Please go ahead, sir.
Yeah, this is regarding the same question as last continuous ascites. And I think this is one case, whatever preventive measure we take it. And one of the patient came after a month with ascites. And the patient had a drainage tube, we removed it, say the second day, went home, came back. And this type of ascites can come not only para-aortic lymphadenectomy, even we had a case in 2 cases, single hernia, gastrectomy, everywhere. So post-operatively, if this patient comes, surgically we can attempt it, no other measure. But the diet measurement is very important. We are successfully treating all these cases by putting a medium chain triglyceride diet. That is a chart, and everybody can go have a look at. So they prescribe the patient for 10 to 15 days time. By the time when the ascites automatically subsides, that particular patient after para-aortic lymphadenectomy, 30th day came, entire ascites disappeared, that patient. And that's why if a post-operatively 3rd, 4th day, 5th day, if you have a drainage as a chylus-like or more fluid, then change the diet like this, then you will have a success in almost all the cases. Unless it is infected like Sir Rao put in one of the cases, got, if you allow it long time, then chylus ascites can get infection. But ascites can be treated medically, and the diet is the most important, and that everyone has to know, look at that part. And well, last almost 20 years, in open cancer also we had, and laparoscopy also, this is one of the things, clue, what we learned from my experience, just putting it.
Absolutely, sir. So it's a very important issue. I would just put some point which all of you told summary for people who want to do pertaining to para-aortic. Remember, the chylus ascites is 0.9%. All chylic is not ascites. It will settle down because it's the lymphatic has not been tied. It has been cut off with the energy source, left to open. It is directly dependent to the number of lymph nodes you remove and positivity. It is the chylus ascites in RP-LND 0.9%. Now the golden rule for this is prevention first. How do you prevent in para-aortic? We and Subba always resolve. It's a rectangle dissection in a para-aortic. If you understand left-hand side of the border of the upper part of the triangle and the roof, you find a triangle. All that has to be clipped at the end of surgery. I always make it a point I do it, so you don't do. So, if you see that renal vein duodenum is the superior border. On the right side, right lateral wall of vena cava, left side, left lateral wall of aorta, below aortic fork. So you have a triangle, rectangle. The roof and the left lateral border, the crescent, at the end of surgery after you give a wash, each one of them hold it and clip it. If you put that, ascites is very low. And the difference between the thoracic chyle leak and this is totally different. In thoracic, you have a leak, you still have a long segment to go down up to right crus and you can ligate. Here, you hit the right lumbar trunk and the beginning of cisterna chyle. It is not the thoracic duct. So there is nothing beyond that for you to do it. It's like, it needs a open surgery to suture. So one is prevent. You see a rectangle, roof, left-hand side, crescent, always ligate, all at the end of it. Number one. Number two, if it happens post-op, as sir told, put on a medium chain, diet. And octreotide has been shown to make high output to low output. If it is going to heal, it's going to heal with these two mechanisms. If it doesn't heal with this, I had a patient referred from outside. Our intervention radiologist gives a lipidol, does a lymphangiogram, and he cannulates this from below and puts a coil and seals it. Success rate is 76%. You don't have to open. In spite of this, if you have to open, the way to do would be that you give an ICG in the first web space of the foot, just as after induction, you put a scope, you throw the ICG camera, you will find where it is leaking, identify and clip it, or give a MCT, that TPN meal through the feeding rice tube. And then you will see that. These are the 5 techniques which are known, which will prevent it to happen. I have actually enlisted in a chapter we wrote on a para-aortic for a gynec FIGO report. This is very useful for everybody. I have another question from, Dr. Arnab. Dr. Arnab has written to Subbu sir, looking at your laparoscopic RP-LND, sir, everything is amenable. Is there any condition you want to do open, sir? Is there any message you want to give? The question from Arnab Gupta is, any situation you would prefer upfront open rather than lap, sir?
At least in endometrium.
Can we mute everybody, please?
In endometrium, when it is operable, then it is it should always be possible to do it minimal access. Anything that is not possible would be inoperable otherwise also. So open surgery is for those who are not well trained in minimal access or do not have a robust team to support through minimal access.
That's fantastic.
Cervix is all open, correct. Ovary is all open, but endometrium, I think, is something that should be done by minimal access. And the place for open surgery is place for open surgery is only when you cannot actually perform minimal access.
Absolutely. It's a very fantastic message.
Because in the past 12 years, so we have not converted a patient for resection. We have not converted a patient for resection. We have converted 2 patients for complication. That too, one on the table for bleed, one on the 5th post-operative day for chyle leak. So to resect, you would never need to convert. Only thing is you need to be well-trained and to have a wonderful team.
Superb, sir. That's
Dr. Chandramohan is still there. Actually, we were going to Chandramohan. Chandramohan, can you please?
Chandramohan, unmute yourself.
Chandramohan has prepared a better presentation than me about both of us. So.
He's a master. We have to take it. Actually, I want to take that.
That's why I interested Chandramohan only.
I don't even remember. I was so fat then, actually, doing exercise.
And I don't know, he caught both of us smiling in a photo.
I know.
He got disconnected, actually.
Okay, then I'll go with the questions which are there. Sir, there is a question from Dr. Ronak Jain. In the process of doing an RPLND, it is not mandatory to clip and ligate the gonadal vessels. So they have written that if you are sort of doing a fertility preserving, and I probably it's very difficult, in which case would you preserve ovary and still do RPLND? It's yet to, I can't find a reason. But they have written if gonadals are hit and injured and gone, does that mean during RPLND you should convert it into a oophorectomy?
Oh no, I think we have to be very, very choosy in this situation, because see, you have a ipsilateral germ cell tumor, for example. Then I think you should do a template-based RPLND. You should not cross onto the other side. That's what we have done recently. We stayed on the left. It was a left-sided tumor. We stayed on the left side, went up to the aorta, identified the gonadal artery, right gonadal artery. Vein is generally safe, and even if it is injured, nothing much happens. So I think you should not venture to dissect around the gonadals if you want to preserve the ovary. It's always good to preserve a completely vascularized normal ovary if you want to achieve fertility. And it's only fair that if you have a early disease, the role of the lymphadenectomy as a staging procedure is in very early disease if you want to avoid chemotherapy. And if there are bulky nodes, of course, on the contralateral side, that is when you'll have to think twice whether you should preserve or not. You could always do an ICG and see whether the ovary is maintaining vascularity or not. So only one experience, but when we needed to do, we preserved the other side. We did the left template only. Yes.
So the message is, remember, it's very important that at the high level of para-aortic, above the IMA, if you accidentally injure the gonadal, automatically it doesn't mean ovary will be devascularized. Same applies to male intestine. Still, there is a vascularity which comes. If the injury is at the lower level, yeah, you may end up with an infarct, but not in the higher up. Best way, what Subbu sir told, is give ICG and do the vascularity, and if there is a good glowing of the ovary, you can leave it, which is quite often in many places, many times actually. There is one question from Rudra, our senior surgical onco. Rudra, you can unmute also and say, what is your experience with magnetic retractors? I have not used, I know Rudra has been sort of, beautifully writing about it in last 2-3 weeks in our IASO. I use a Versa band magnetic retractor. What do you want to say about it, Subbu sir?
He himself is a magnet. Rudra himself is a magnet. Chained magnet, MRI magnet.
It was one of the best presentation as usual with Subbu sir and Som moderating. But last week, actually, Manas from Bhubaneswar, AIMS Bhubaneswar, he had a webinar where the person from Giuliano from Argentina, he was showing the magnetic robots where on the table the stands magnetic one part is fixed, but inside everything is free actually. There is nothing going inside. So only in one port, single port, he takes all the magnets inside and he manipulates them to do multiple retractor. and then he does it. Actually, it was so good that I thought that Para-Aortic will be the best bet for this.
Yes.
Yeah, so I think Brazil also some surgeon was there, and both of them were discussing this just like I was remembering the doll technique of doing the retraction previously for the initial days of Laparoscopic when people were using sutures in the gallbladder to decrease the number of ports. The same way, the magnets can be used to that might become the future of laparoscopic para-aortic disease.
So, Subbu sir, there is a question from one Dr. Sindhu RS in the chat box. She has written that in your videos you showed that you have an average 15, 20, 30 nodes. There are some nodes which may be positive, which may by malignancy, and they're adherent to the vein, and you remove them. Do you label those what appear to be positive nodes separately? Does the management change, or like everybody goes for radiation, or only do you identify the location of positive node in para-aortic? In your institution, do you tailor make any treatment based on which nodal group in para-aortic came positive? Do you do that? That's a question.
I have to humbly submit that we have not done it in the past. So we have started that in the recent past. We have become much more scientific, if I have to use that word, in the recent past. We have not done it before.
That's super.
We just put it in one box and send. Okay. I'm being honest. Yes.
Okay. Because if you separate it, then you will know 71% of the time it is above renal vein and 36 is left.
Correct.
Sir, our Bangladesh colleague, Janatun madam, Bangladesh whole gynae onco society has logged in for you. The moment they saw Subbu's name, official holiday in Bangladesh, and all are directly logged into this. So there is a, in the chat box, there is a question from her. They wanted to know, not pertaining to RPL India alone, when you do a laparoscopic staging for a surgery, if you do omentum and if there is no hysterectomy to remove it, the natural orifice, how do you remove the omentum? So they really want to know this. It has come many times, and you have to solve their misery now.
You'll have to make if it is total omentectomy, you'll have to make an incision. You can, if it is a normal omentum, you can bisect it and get it through a small incision. But otherwise, I think you should make an incision. You can widen the right hand working port, which will be 12 to 13 mm port, or you can make a fan and steel and remove.
Fantastic.
It doesn't hurt too much. As long as you don't retract, it doesn't produce too much of pain. All the pain syndrome that the patient, open surgery patients have, is because of the retraction that you do. Here you don't retract, you just bring the specimen out, and it's a flexible specimen. It will be a small incision.
Super. There is a question in chat box at multiple times by our colleague Dr. Sarika Gupta. She says, is there any tip and tricks to do IVC suturing? You already told, preload the 2 knots so it self-retains and you do it. Is there anything extra you want to share as per the question asked by Dr. Sarika Gupta in our chat box?
What is important is not to use instrumentation on the KEVA especially. It's impossible, especially, I don't know, when the CVP is low, it may be possible, but it's impossible to hold well enough for it to stop bleeding. So best is, you should have had a gauze piece inside. Any good dissector will always have a gauze piece inside, not always anticipating bleeding, but to mop it up so that the field looks clear, so that the surgery looks better. The recording that you have, if you want to edit, looks much better. So press a gauze piece, wait for a while, and many times it stops. If it doesn't stop, when you take it out and it continues to bleed, and that is when I think you must go in with a 5-0 rolling. And what problem you always face, especially if you don't have the best of the hands. If you are a master in your suturing, it's different. But otherwise, the 5 mm needle holder, the tip of it, the 5 mm needle holder, I think is a little too much for 5-0. This is something that I keep seeing. It occupies most of the shaft of the needle, and while you are going in, if you are holding it at the eye, the grip is not proper. If you are holding it at its body, the tip is not enough for it to maneuver completely. So it requires a 2-point motion which can induce a little more bleed. So what I actually asked our people to do is, you must have a 5 mm shaft with a 3 mm tip. So if you have a dolphin tip, a 3 mm tip in a 5 mm instrument shaft, I think that will be the best needle holder, which can be very easily developed. So I've asked one of the biomedical fellow to do this for us. I didn't have a bleed after that. So once I try that, I'll send that also to you.
Superb, sir. Superb. For beginners, Sarika has written a lot of things about difficulty in breathing in IVC. I'll tell you one thing. 3 most important steps. Underhydrate if you're doing an RPLND. Trend lumbar position. When I put my scope, if vena cava is biconvex distended, I will never proceed. I just call my anesthetist, show the monitor, I tell I'm going for a cup of coffee. I'll come back after 10 minutes. Vena cava needs to be collapsed with low CVP. When it is collapsed, it's easy to lift and suture it, because when it is convex and distended. So these 3 are very important. Underhydrate during RPLND part, trend lumbar, vena cava collapse with low CVP. It's very, very easy, very less. Oozings stop, minor bleed, major bleed appear like minor bleed appears like ooze don't happen. If you have a, it's very easy.
You can even see the edges of the wound.
Yes, I know it's very easy. It's very pliable. You can lift it like a skin fold, and then you can actually apply a right angle and then suture it. If it is biconvex, you don't. I never do para-aortic if vena cava is distended or biconvex. I just descrub, go have a cup of coffee and come back until it is collapsed.
I'm really shocked at my ignorance, Baiju and Som, about this CVP stuff. We never thought about it. Really, I've really learned so much.
That will save your life a lot.
Pardon me?
That will save your life.
Yes, correct. True.
That's fantastic. And if Chandra Mohan has come online, can Chandra Mohan?
The net is actually is come. Okay. Chandru.
And he has a halo around him.
Yeah.
Not Halloween.
Remember,
not Halloween. Halo.
Yeah, before I hand over to Chandra Mohan, for a beginner in para-aortic, remember, one is the CVP, low hydration, and then trend lumbar. Knowing where are those 2 fellows vein and 3 Adinklos artery at the anterior spinal ligament, because interaortocaval area dissection is very important. Then you would see 3 Adinklos artery. So 2 fellows vein, 3 Adinklos artery, 4 lumbar veins running obliquely. That's why you have a midline split lateral row technique. You cannot get a para-aortic in one piece. And if you look at these steps, they're very, very important. You don't end up with the hemorrhage. Rest all can be managed. That's what deters us. Chandru, over to you. Our CM, we always call him fondly CM, Chief Minister, CM.
I think you are setting and it got the perfect message across. But I just want to add up something, because please understand, we are here with now 163 people, 300 witness, and these things are done by masters of laparoscopy, and it is very, very hard procedure for a beginner. And one more thing is the importance of the teamwork. The fact that Dr. Subbu never noticed IVC's collapse because he had a team already doing it, and for him there is no necessity to instruct those people because he has a fantastic team of anesthesia. I really has to the team, assistants, and everybody plays a role. So unless you have the system in place, I think such things should be done very cautiously and very judiciously. And there is no shame in converting for the beginners. I think the life of the patient is the sacrosanct thing. And this message should be reiterated. Otherwise, laparoscopy will do more harm in inexperienced hands than open surgery. And the potential of laparoscopy is enormous. And we need torchbearers and inspirers, like Palnivelu, Dr. Subramanyeshwar Rao, then robotic, we have Somasekhar and SENADHIPAN. At the same time, the patient's safety has to be preserved. That message has to go across. And it was a fantastic evening with you. Both of you are essential in complementing and compensating, and this good. Baiju, really hats off to you.
Thank you, Chandru, for the nice words. We would like to move on Many people, Dr. Chitradara from Cochin, Dr. Manjusha from Mumbai, all gynec oncosurgeons has joined. If they are there, please unmute and say some words.
Chitra, welcome. Can you unmute? Yeah.
I think I got disconnected.
Good. Anyway, until they log in, for students, I would strongly recommend to read BJOG 2011 edition, British Journal of Gynae Onco 2011 issue. Now we have a new Pommel's classification of para-aortic lymphadenectomy, which is divided into systematic A1, A2, A3. Then, just staging B1, B2 and sampling. Non-excisional but surgical means of para-aortic assessment called C1, C2, C3. So this is called as Pommel's classification. Please read it, BJOG 2011. What we all do up to renal vein systematic is most of the time called as Pommel's A2 type of classification. A1 is you go up to celiac trunk. We rarely do that.
Yeah, Dr. Avinash Saklani has joined. Dr. Avinash.
Good.
Can you please
Saklani, welcome.
Saklani from Tata Memorial Hospital, Mumbai. Saklani.
Saklani, unmute yourself. I think you can unmute probably. Or let me see if I can unmute.
Shailashri is there. I can see Shailashri.
Shaila, welcome. Shaila is our fantastic laparoscopic gynae onco professor of TMH Mumbai, who was in UK, and a great poet, and she's a lifeline of our Agai WhatsApp group.
Oh, is
Can
it?
you hear me? Hi.
Shaila, go ahead.
It's not Avnish. I came late.
You logged in with his user ID.
No, sorry. Very excellent. I was expecting this, and it's Dr. Subbu sir has done a good job. And obviously, I was telling Dr. Somasekhar, they are both complementing each other. It's a nice duo. I've got some experience, not as much as Dr. Subbu sir, in doing para-aortic lymphadenectomy. I've done a few retroperitoneal as well. I learned from LeBlanc to the extent he made my index finger go and create the spaces and showed me, gave his teeth lifts and also his bipolar tip. But I use Maryland, curved Maryland for these procedures. That's it, I think. But this is excellent. Anything else?
Super. Huh?
Good. Very good. Very good presentation. Lovely. It was very lovely.
Thank you very much, Shaila.
Yeah.
I agree with the retroperitoneal route that the other side of the IVC is not seen, so you're struggling, but otherwise the bowels are not there. So it's really excellent to go through that route and do the left side well. But right side, yes, I agree. If there are no notes, then it's decent enough. Otherwise, it's not. And Prof. LeBlanc did retroperitoneal route on both sides. He went from the left side. I asked him, he said nowadays he's going from the other side as well and doing both sides. So he's doing ports on both sides and removing retroperitoneally up to the renal highway.
That's a Dargent's technique. Yeah.
Yeah. Thank you.
When we have such obese patients, I think that will be a better technique. I surrender to a real obese patient. We don't see such huge patients. So I think it depends on where you are. Our patients, I think transperitoneal alone may be enough, but their patients, I think retroperitoneal will be a better technique in some patients.
And another tip, another technique which I quite often started doing in obese patients with a fatty para-aortic area is, I give ICG not with an intention to do ICG based SLNB, but my ICG, I give all the nodes light up. It sort of gives me a way not to sway away to the normal area to read complication. So I give ICG to do a systematic para-aortic lymphadenectomy to stay on track. They say, no, you must stay on the putty, on the rail. So I really find it. I used to do it in colon surgery to do Japanese D3 CMV, just give ICG, not with an intention of SLNB. It really shows up the whole array of nodes. Then you know where to stay focused, and you get a more good yield. Sometimes in a bulky obese patient, when everything is fat back, ICG guides us to define the boundaries sometimes.
Very true. Very true. Actually, that will stay as a real indication. Once as the imaging systems are improving, what we have now is, see, the problem with ICG guided surgery was you needed to swap the camera. You keep on using your foot pedal to swap, see, get back to normal mode and do. Now there is an overlay mode wherein both the white light and the white light camera and the NIFR camera are working, and the images are processed simultaneously. So you can see real time and see the green also.
Absolutely.
Normal anatomy and the greenness both are seen. So I think that has made it really excellent. Further improvement will only make it, you will be doing it in every patient.
Absolutely. Rudra, you have a question? You raised the hand.
Yeah, just
yeah, go ahead, Rudra, go ahead.
Just I was curious about the knot at the end of the suture. Actually, in one of the cases where the knot was there, but the knot also passed through the rent in the IVC, and it became a bigger rent. So one of the vascular surgeons was around, and he gave me pledget suture. Pledget is nothing but a square of gel foam is at the end of the knot, beyond the knot. And with that one suture, the pledget is that gel foam got stuck to the hole, and the knot was very nicely fitting to the place. So that gave a complete perfect hemostasis. So this can also be a tip to correct the.
Absolutely. It's a good idea. It's a very good idea.
Absolutely. And if you see the robotic partial nephrectomy they use, two pledgets on either side, and you can slide. It's like it gives a compression. So
correct.
Yeah, that gives a very good one.
It's a good idea.
Fantastic. If anybody has any question open, it goes on and on. It would go up to midnight, and we would say tomorrow morning date also. I would invite Baiju Senadhipati to take it for the closing remarks. If anybody has a question, we are open for that.
Yeah. Actually, we had logins up to 425 today. That means that we gave it in YouTube also. Actually, the number of logins will be almost 1,200 as we usually.
Super. Yeah. And this recording is going to be available, and the link will be known, so people who miss can re-attend.
Before I go to the last conclusion remarks, Dr. Thomas Varghese is there in the audience. He is an oncosurgeon in Cochin. Can you please unmute, Dr. Thomas?
Yes, I am unmuted.
Very good. Thomas, welcome. Good evening.
Hi. I am glued to the screen from 7:50 onwards. Super. Come on, Baiju is doing a yeoman service and excellent academic feast. Subbu, I think you are a maverick on the laparoscope. But better than that, the oncology part of it. And with the Somasekhar adding spice to it, no wonder the meeting will be much, much superior to what you can ever dream of. Somu, thanks for all the tips and tricks. But I want to ask Subbu one question. You said about your conversions and you will not convert. I saw you dissecting on the vein where the node was stuck. What will give you guarantee that in such nodes, when you dissect, there won't be any residual disease left behind on the vein? Second question, anytime, can we do a resection of the vein, partial venectomy, for the sake of completion of removal of the adherent node? Have you done any experience?
No. See, now, whether it is even in open surgery, there may be situations wherein adherence can lead to partial resections. whether resections will help these patients or not is something that cannot be easily answered. A node which is so advanced should generally be considered as not curable. But I think you must make every attempt to resect everything.
No, I saw you dissecting on the vein, and it was not, personally speaking, I don't know whether you'll be able to completely clear it. That's my question. So how will you make sure after doing a very excellent surgery, but for that small part on the vein, the disease is left behind?
If I had a doubt, I would have resected it.
No, the question is,
no way, it's only visual impression.
Question is, will you back out from the procedure? Will you back out from the procedure? That's my question.
No, I've never backed out. I would have resected it. I would have resected the cava. Because resection is not a difficult procedure at all. Maybe I would have converted to resect. Correct.
Absolutely.
Is always
the message what Subbu said, I totally agree with Subbu sir. What he wanted to say is, what he would do in an open surgery to remove that node, which is a sharp dissection, he would do it. If he thinks that it needs a vein wall removal, he would do it. Go ahead and do it, because you can always put a staple across the right wedge of the vena cava. If any place he thinks that it needs a resection to achieve R0, he would go ahead and do that. And he would use a sharp dissection to cut through the vein wall along with the node with the capsule. If that's what he would have done in an open surgery. I have been in many of the circumstances, and I fully agree that I do the same thing.
No, like a venotomy, will you do and open and remove the thing, and then you close the vein?
Yes.
Okay.
Yes.
Thank you. Excellent.
Thank you.
Lot of information. Thank you, Baiju.
Thank you so much. So we had a lot of, we had a lot of logins from lot of stalwarts like Dr. Palanivelu, Dr. Ayyappan, Dr. Parveen Bhatia was there, Dr. Surendra Ugale was there, Dr. Neeta Bhatti was there, Dr. Chitradara was there. Lot of stalwarts are logged in. Now we will have to conclude because it has passed at 10:30. So thank you very much. It's all happened. The logins, 1,200 logins all over the world happened because of one person, that is Dr. Subramanyeshwar Rao. Because of you, because of you only, this much of audience has come to this forum. And I thank you for accepting my invitation, and thank Dr. Somasekhar also for accepting my invitation to moderate this session, and thank Dr. Chandramohan for introducing this speaker and moderator. We need you in the future endeavors of SENADHIPAN Education Foundation. Also, you over to Dr. Subramanyeshwar Rao for the concluding remarks.
It's a great honor, Baiju. One of the best days in my life, to be very honest, to be along with Somasekhar and to be a part of SENADHIPAN Education Foundation. The energy levels that you have in conducting these programs, not ruffled by any rough weather that it creates, is something that shocks me. Today in the WhatsApp group that you have created, you have started a countdown, which means you have started the race in the morning itself. Every 2 hours, 4 hours to go, 2 hours to go, and you are egging people to be ready for the show. So, being a very prolific surgeon and a busy practitioner, your energy in multiple directions is something that the youngsters should pick up. Whether they do it or not, I'm going to pick up this energy from you, and I'm sure I would be a better person, better surgeon, and a better teacher from tomorrow. I really gained from this evening. If many others gain from my presence here, I feel blessed. Thank you, Som, for being a kid brother, all through and in this session too. Chandramohan, for that wonderful introduction. Thank you very much.
Super. Thank you very much, sir. When you know Baiju told me it is Subbu sir on this topic, we all know that when Dharmaraya, after all the Pandavas left, he started climbing to reach the heaven. There was one dog which piggy banked it, and the moment he told it is Subbu sir's name, I just realized just getting associated with him in any form, even as a janitor or just somebody who just holds his bag and walks behind him, we also will see the glory. And you actually gave a glory to all your students and all your people, fellows you have trained, whom you have mentored, all of us, and a warm thank you, hug, love, affection to you. God give you a lot of health. You train more, save a lot of patients, devise more techniques like this, make it simple, and train more and more people, be an inspiration to all of us. And I really thank you very much, sir, and it's an honor to be
Great
part in
time.
any form with you. And
Great time. God bless you all.
Thank you.
Thank
you.
you.
Bless Baiju, God bless
Even now, almost 100 participants are still in the late night, 10:40 now. So even 100 participants are still there. It's all because of you only. Thank you all who are logged in from different parts of the world. We'll see next week with a new speaker. Mostly it will be Rutledge, who has invented mini bypass. He will be delivering a lecture on mini bypass. I am awaiting his last consent on this talk. Till then, bye. Thank you all.
Thank you. Thank you very much.